Okay. Yeah, I suggest that we get started. I'd like to start with acknowledging the traditional owners of the land in which this event is taking place, the Wiradjuri people of the Kulin Nation, and pay respect to their elders and families past and present. So I'm Martin Eisenman. I'm a new chair in Cancer Health Service Research in the University of Melbourne, the Victorian Comprehensive Cancer Centre. It's a great privilege to be here, to be able to introduce you to this lunch session, a special lunch session entitled "A Surgeon, a Scientist, and a Robot Walking to the Bar." And so what's happening now? I'm very curious to see him during the rest of the lunch meeting. We will have two distinguished speakers today, and I'll introduce them quickly. Adhika Murphy is a speaker. He's a consultant urologist and the director of urinary oncology at Peter Mac, and he's an associate professor at the University of Melbourne. In Melbourne. He's a recognized leader in oncology and surgery in prostate cancer in particular, and we just learned he's a cyclist as well. Very important. As a Dutch from the Netherlands, originally, I'm a cyclist. Professor Rob Ramsey is a cancer researcher at Peter Mac since 1995. He's done a PhD in biochemistry, gained at the University of Queensland. Is based on research in melanoma genetics at Queensland Institute for Medical Research. Been postdoc at Memorial Sloan Kettering in New York, and was an NHMRC Fellows in 2016. So they will present to us a very interesting lunch session organised by the Victorian Comprehensive Cancer Centre, an alliance of 10 renowned institutions here in Melbourne that coordinate cancer care to improve cancer outcomes. Please welcome me and give a applause to the speakers. Let's start.
Ladies and gentlemen, thank you very much for sticking around for the last session of this International Surgery Conference here in Chicago. I'm really grateful for you to stay this last session. It's been a big week. In fact, last night was pretty outrageous, I have to say, and I have to apologise on behalf of all the Australians who are dancing on the tables. So what I'm going to do today is tell you a little bit about the research which has been conducted in my laboratory at Peter MacCallum Cancer Centre back in Melbourne. And I'm going to tell you how it fits with the surgery program and the GI tumour stream. So, as with all conferences, it's very important to make disclosures about the people and organisations that support your work. And I am going to do this now. I have a number of supporters to the research that I'm going to describe. Most particularly, I work with a company called Fisher & Paykel Healthcare, which you'll understand as I go through is an important disclosure. I have no stocks or shares, and I feel completely innocent in talking about this work today. Now, here we go. These American computers do this every time.
It's the Russians there.
Here we go. So, let me give you a bit of an oversight. I know you've been hearing about surgery for days, but I'm going to give you my perspective about surgery. And as surgeons, you'll be attentive and you'll take heed of everything I have to say. So we all agree that surgery is highly effective, and in many instances it works extremely well, and indeed it leads to cures. About 60% of patients with cancer will have an encounter with a surgeon in the operating room. Not like the encounters I saw in the bar last night. Anyway, technological developments are very important in surgery. It's actually a very technologically driven specialty, and there are leaders of the pack who love new toys. Not only do they like their Ferraris and their Porsches, but they love instrumentation. And that's making a huge difference into the areas that surgeons can work, and actually the time and recovery of patients following surgery. Even so, it would be fair to say there's a large number of areas that could still be improved upon, and that's what I'm going to talk to you about today. So I always hold the view that evidence-based research is essential for the development of any area of medical research, and surgery is no exception. So the way I began this journey to interact with surgeons was through a program we developed at Peter Mac around about 2012, where we decided we'd bring all the parties together across the campus to talk about their own specialty, to get the surgeons, the medical oncologists, radiation oncologists, the nutritionists, the physios, the nurse practitioners, and the researchers in one room and say, what can we do about the GI tumour stream or the breast service? And this was an opportunity for us to talk to each other. It was very interesting because the first thing that was evident was that some of the people, even in the medical area, had not met each other before. And certainly what was very clear was the clinical side was not talking to the research side and vice versa. As a result of that meeting, I got to know two colleagues who have become very close working colleagues and friends. One's a professor of surgery, Sandy Herriot, and the other is Associate Professor Craig Lynch. I asked them a very simple question. I said, what's this MDM thing? This acronym, and it was actually a medical or multidisciplinary team meeting. I said, can I come along and see one? Of course, very welcome. No one wants to come. In fact, even the people there sometimes don't want to go. But I was invited along and I said, great, when is it? Oh, Friday morning, 7 a.m. Great. I think that's one of the reasons why people don't go. Anyway, I took the opportunity to go, got on my bicycle in the dark and rode there, and on occasion I rode there in the rain. But I love it. It's been the most informative experience of my research life, because what it did to me was it changed my perspective from thinking about the experiments I can do in the laboratory to thinking about the experiments that we agree to do in the laboratory, which are directly relevant to what happens to our patients. Goodness me, this American projector. Here we go. So, to cut down to the tin tacks on this, what we're talking about is how can we use research to improve the journey of a patient through our organisation and others to get the best outcomes for our patients. And it begins before there's an intervention. It begins at diagnosis, and that's where we build up patients so they're strong for the journey that's ahead of them. And of course, we need to think about nutrition and support and exercise at the end. We've got fantastic imaging in this precinct. It's very important. And there's a lot of important developments in chemo, radio, and now immunotherapy. We have a strong interest in anaesthesia, and I actually do some anaesthesia research with my colleagues, and I'll tell you about that later. And of course, part of the discussion here at this conference is about surgery research, and there are many things we can do to improve that, including thrombus control, which is a very important part of post-surgery. And then ultimately, we're hoping that the patient will go home early, well, and their family will be able to support them in every way. And that's what we're really on about. So one of the initiatives that arose out of the 2012 meeting was progressively one of my colleagues and I were very keen to put together a GI cancer program. Wayne Phillips and I decided that we'd try to put this together with as many colleagues in this precinct as we could. And on one side, you can see a constellation of clinical stars, and on this side, you've got us researchers. And basically, what we're trying to do is have a dialogue which runs both directions, from the clinic into the lab and the lab into the clinic. The arrows I point out here is a picture from my lab last year, and they indicate the surgeons that are now or have been in my lab doing research. They're doing PhDs, trying to learn the ways of being a researcher, and similarly teaching us in the lab what the real problems are in the clinic. So the first conversation I had with my clinical colleagues was basically incomprehensible to me. They talked with all these jargons and acronyms, and I didn't quite understand what was going on. The first one I didn't understand was the term insufflation. I thought it was some kind of vacuuming a technique or something that you would get at Godfrey's. However, it's very important. It's central to what I'm going to talk about. Insufflation is the process by which you inflate the abdomen so the surgeon can put in instruments and scopes and cameras to actually operate in keyhole surgery context. This has been around for quite a long time. Some of the earlier gases were not so helpful because they're explosive, and when a surgery knife, which is actually an electrical device, ignites the gas in an abdomen, all sorts of unhappy things happen. Now we tend to use carbon dioxide, and that's probably a very good thing. And what I became very interested in talking to my surgery colleagues is this surface that surrounds the abdomen called the peritoneum. It's surrounded by this really cool single cell layer of mesothelial cells. It's not so important that you know what the cell type is, but you need to know it's very thin, and indeed it's quite fragile. If you think about that surface, it's doing many things. It's got many microvilli. Each individual cell has between 300 and 600 microvilli per cell. That's lots of these little finger structures. What they allow is a large amount of exchange because the surface area is huge. Exchange of gases, nutrients, hormones, all sorts of things, and also places to hide, I suppose. In addition, it creates what's like two carpet surfaces that allow tissues to move across each other. So the organs within your abdomen, and if you listen to someone's tummy particularly, you can remember your kids doing it to you, they can hear your stomach moving around, and your abdomen is actually quite mobile. To move one surface across another, you need to avoid any adhesions or restrictions, and that's what that surface does. So during insufflation, this word that now I'm very comfortable to use, we introduce carbon dioxide into the abdomen to create a pneumoperitoneum, that is an inflated abdomen. The gas that we choose is carbon dioxide. It's relatively inert, it's very diffusible, but it comes out of a gas bottle, cold and dry. And the questions posed by my colleagues is what happens when we use this gas? Are we doing any harm during the surgery procedure? And of course, the reason they were thinking that is there was a company that was working on a device which humidified and warmed the gas before it entered the abdomen. The reasoning being, instead of a cold blast of CO2, you'd introduce a warm, tropical delivery of carbon dioxide with the intent of reducing desiccation. And that's the device that I'm going to tell you about today. Why do we care about this? Well, the abdomen is a very interesting place. The mesothelial cells are very interesting, but if they're damaged, they become a great place for tumours to grow. The reason is there's a basement layer that is very attractive to any cell, but particularly cancer cells. And in the context of that, we also know that in our service, a large number of patients develop peritoneal cancer, particularly towards the end of their journey. Peritoneal cancer is very hard to manage, and there's a whole lot of surgery technology that's involved in improving the outcomes of those patients. But today, I'm only going to focus on some of our research. So, as you would know, in the laboratory, we're restricted in what we can do in patients. I'm not allowed to go near a patient. I'm friendly towards them in the lifts, but I'm not allowed to touch them. But what I am allowed to do is I'm allowed to simulate and recapitulate some of the things we do in the clinic in the laboratory animal. And we use mice. We use them because they're not so much cheap, but we understand their genetics exquisitely, and we can control the environment they're in. And when we do an experiment, we can control a whole lot of variables at once. So we've been doing some insufflation experiments in mice. And the outcome of that is if you introduce carbon dioxide into the abdomen and you damage it, we can get tumour cells to grow in there very well. And I'll just show you the differences between these two modalities of carbon dioxide delivery. These are experiments conducted by Sandra Carpentieri and Sheeny Sampuro, two of the people in my lab. Sandra's now doing something else, but they have done an amazing amount of work in this space, and I wouldn't be able to talk to you about it today if it wasn't for their efforts. And I'm going to show you what Sandra and Sheeny did. Now, those of you who are interested in mice, they're very cute. This is a Baldstein mouse, which we anaesthetize. But we actually have to replicate everything we see in a patient. We need to intubate them, actually keep their respiratory function going properly. And to do that, it's rather tricky because they've got a tiny little orifice where you need to slot a catheter in there to deliver oxygen. and they got very clever at this. This was not a trivial matter. Even the young surgeons who come into the lab have to learn how to do this. So we need to keep the animal respiratory function running properly. We monitor pulse, blood pressure, and temperature. We also have to introduce the similar kind of concept of the ports into the abdomen to insufflate the animal. And you can see now that the abdomen is blown up just like you'd see in a patient. We do this over an hour's period of time, one with cold dry gas and one with warm humidified gas. We have an exit port on the other side, just like you do in the OR. This is the device which warms up the CO2, adds moisture, so now we can avoid desiccation, and we monitor a number of things. We have a rather undignified delivery of a rectal probe up the mouse's, you know where, to monitor temperature over time. But that's very important because temperature is relevant to the outcome of patients during surgery. Meanwhile, someone goes back to the lab and gets some cancer cells out of the laboratory. And then we introduce an infinitesimal number of cells into the peritoneum, and we ask, what happens to the tumour cells under the two gas conditions? The mice recover well. We actually didn't lose many patients in this procedure. And we measured various things. And I'm not going to go into the details because you as surgeons don't understand a lot of molecular biology, but I'll go through the basics. COX-2, this molecule over here, is highly involved in inflammation. And when it's cold and dry with the CO2, it's increased. Another marker is called VEGF-A, involved in a number of things, including inflammation, and we change it when we use warm humidified gas. And over time, macrophages, or these phagocytic cells, increase more in the cold dry group than in the warm humidified, which is indicative of there being damage that needs to be repaired. What happens to the structure of those acute mesothelial cells? Remember, we've got all those microvilli. Can we measure them? Well, yes, we can. We use a technique called scanning electron microscopy, which allows us to look at the structure of these cells. And when we do that, we can show that the cold dry group basically loses the microvilli. And indeed, the mesothelial cells start crunching up and delaminating. Now remember, we're losing the ability of the carpet to work now, so this might be important. Indeed, not our work, but others that have published in this area have shown that when you get that delamination of the mesothelial cells, the tissues stick together. And they're called adhesions. The adhesions are a complication of surgery that we'd like to minimize, particularly in gynecological surgery. What about the tumour cells? Well, first up, within a couple of hours, we can see that, back one. We can see that in the cold dry group, a lot more tumour cells stick. That's just the beginning within the first couple of hours. So is this important? Remember what I was talking to you about, that peritoneal cancers are actually indeed an issue in our GI service, and in fact, often hidden behind the fact that patients may have synchronous metastases to their liver or their lungs. So we can identify small numbers of peritoneal tumours on the mouse, and we can use all sorts of slick technology to pick it up using technology that labels the cell with fluorescent markers, and we can harvest the tumours and identify them. This is a tumour that's grown within 10 days in these mice. It's a fantastic place to grow tumours. It's just not very good for the mice, I'm afraid. And when we measure the tumour burden in the two groups, excuse me, I'll have some Chicago water. If you measure it in the two groups, there's a significant difference between the two modalities. So the bottom line is that even with a really small number of cells, we can show a big difference in the adhesion of tumour cells just by swapping the gas. Pretty simple. Okay, what about open surgery? This is starting to get a little bit more challenging. Is there a place for carbon dioxide in this context? And what happens if you use warm humidified CO2? Well, let's just show you what happens when you deliver carbon dioxide into an abdomen without a filter. Blows out, and if you, whoops, let me go back. if you use a diffuser, quite simple technology, it still involves some engineering, you can basically fill up the abdomen with carbon dioxide. So now we could address this question in open surgery. And indeed, we set up a surgical suite once again, but now we do open surgery. We hold open the animal's abdomen over a period of an hour, and we do the same thing. And just by changing from passive airflow to using this diffuser device, we can maintain normothermia in the animals pretty much from the get-go. We also affect peripheral perfusion. So we can measure perfusion in an animal's paw at distance from the surgery site, and the carbon dioxide that we're delivering is basically preserving the exchange which is happening in the peritoneum. It's not the carbon dioxide we're measuring, but we're preserving the surfaces of the peritoneum, keeping them moist and warm, and indeed allowing exchange to occur there. We also could start simulating surgery, which is something that we were very keen to understand in the animals as well. And we once again employed this scanning electron microscopy to document all the structural integrity of the peritoneum or otherwise. And indeed, just by adding warm humidified gas, we reduced the amount of damage generated just by having the abdomen open. We didn't do anything else. However, by 10 days later, when we harvested another group of mice, all the peritoneum was back to normal, looked fine, except where we introduced some surgery damage. We simulated it on one side, and the carbon dioxide that's been warmed and humidified led to a greater recovery of 10 days. So this is very interesting to me because mice are extremely resilient, very fast to repair, and yet the surgery damage persisted for 10 days in the normal group or the unintervened group, and the group we added warm CO2 were actually able to restore that faster. And now we're actually changing our approach a little bit. What I described was a passive airflow in the operating room. It's HEPA filtered. In fact, there's 20 volumes of room gas exchanged every hour. So you actually can feel a breeze when you're in the OR. So we're now starting to simulate that in our animals as well. Okay, so I know you as surgeons don't give a hoot about a mouse. You don't do operations on mice. You don't build them. They're not part of your patient group. And I know you don't care about mice, but they're a great model system. Okay, where did you train? How did you learn how to do a laparoscopy? Well, many of you would have learned how to do it on larger animals, particularly the pig. And indeed, the peritoneum of the pig looks essentially the same. I would defy you to pick the difference between the mouse and the pig's peritoneum under scanning electron microscopy conditions. And we also investigated what happened in the pigs during cold dry, warm humidified, and then we introduced another element, a device that is very popular during robotic surgery, I've heard. And this device is called AirSeal. It's actually fantastic for maintaining a very stable pneumoperitoneum. But indeed, it generates damage as well. Indeed, it generates a lot more damage than passive insufflation with cold dry gas. We've investigated a number of molecular markers, but I don't want to bore you with those. This is a marker which monitors hypoxia. It's a very good molecular marker for hypoxia. And as you can see, the warm humidified gas seems to lead to less hypoxia. Who cares about hypoxia? Well, tumour cells love it. That's where they like to grow. So all this is very nice. We've done mice, we've done it in pigs, and now we're actually replicating these studies in a group of patients to understand whether the same mechanical damage that we believe we introduced with cold dry gas could be replicated in patients. And these are my colleagues that I've been working with. You can see here, I look the least surgical of all of them, but this is as close as I ever get to a patient. We're monitoring these cohorts of patients in 4 groups: cold dry, warm humidified keyhole or laparoscopic, and we're doing passive airflow, or the flow you get in an OR, with open surgery, and then we're introducing with the diffuser, the 4th group, with warm humidified CO2. That trial is being conducted now. The bottom line for me as a lab researcher, not as a surgeon, I know you're all getting very tired because you've had a late night. The The bottom line for me is that don't do damage to the peritoneum if you can avoid it. These are the people in my lab, and some of my clinical colleagues. I mentioned them as I was going through. This is just part of the story of what's going on in our GI tumour stream and what we're trying to do in surgery. So normally I take questions because I love questions, but I've had enough. I'm going to go and leave you all, and I'm going off for a while, and I appreciate you coming. See you next year. I think the conference is in Barcelona, is that right? And I look forward to seeing you then. So see you later. Here, please. Hey. I'm good. Let's be quiet. Right, here we go. How you going? Rob. Yeah, nice to meet you too.
What are you going to tell? Local?
I'm here for the conference. I've been here all week. I've been hanging out with surgeons. I'm not sure. They certainly weren't that interested in what I had to say this afternoon. But anyway, all done now. Oh.
We got the
Spa has the microphone.
no such thing as privacy anymore.
I know that.
Social media.
Yeah. There's some people in surgery I've heard are really big into Twitter. Have you heard that?
Yeah.
Yeah.
It's mostly marketing for the photograph.
Oh, that's good then. Well, that'd be ethical. It's good. So, guess I'm going to have to talk. I mean,
don't make small talk. I don't mind.
No, it's rude of me. I'm just a bit tired. I had a big night last night. That table dancing just about killed me.
Really?
I was at this surgery conference, an international one at the McCormick Centre. Oh, what a surgeons.
Yeah.
Wow. They all went out to these really nice places for dinner, so I didn't get invited.
What sort of surgery do you do?
Well, that's the problem. I'm not really a surgeon. I'm a researcher. I know I'm embarrassed to say it, but I do spend a lot of time with surgeons, and actually I quite like some of them. Not all, most. Yeah.
I'm a surgeon in this one.
Oh, sorry.
But I'm
Were
shy as well.
you at the conference?
I was, but you know, the football was on last night. So we pushed on to that sports bar down at the corner of McCormick, Foxy Lady.
Oh, yes.
And
Yeah, I was at Hooters for a while.
Yeah.
I was forced to go, but anyway.
I texted my wife and said, you know, I can't watch the football anywhere. And so if the credit card comes up with a place that sounds like a dirty strip joint, I'm just trying to watch football.
That's
And then
so,
I pushed on.
I believe you're a surgeon. Yeah, it makes good sense.
I pushed on, and then I was, you know, suddenly the sun came up, and I staggered into this satellite session called Translational Research. What's it all about?
You came to my talk.
Oh, look, I have to apologize. It just said free breakfast.
Well, you had to hang around a long time. Maybe that's why you
I was down the back and
Yeah. So what a sleeping surgeons are nice. Can I ask, what sort of surgery do you do?
robot surgery.
Oh, okay, well, let's move on.
Everybody loves this shit. It's all over the place.
Well, I must confess, I find it fascinating. My father was a fitter and I'm really into engineering. I could put engines together, and I used to race motorbikes. I love that sort of physical stuff, but it seems pretty complicated.
Yeah, but you know, that has the allure of better outcomes and stuff like that. So if you make stuff unnecessarily complicated, lasers, robots, keyhole surgery, it just sounds good. So
I thought it was all about getting inside a console and reliving sort of computer games.
But it is a bit like that, but the one session I did go to yesterday was all about machine learning and AI. I don't even know AI. And I realized that to be relevant in a few years' time, I'm going to have to get up to speed with this machine learning. I mean, for example, my cousin, who's an administrator in a cancer center, said that he's not going to have a job in 5 years' time. So we started this conversation. He said, well, I've done an MBA and I've done this and I run the cancer center, but robots can do all this shit. They can do the HR, they can apply for grants, they can write the papers, this anti-plagiarism software is all going out the window.
They can write the grants.
Yeah, and then his wife, who she's a bank manager, and they've closed down all the banks because the machine learning and the AI really taken over. Scientists, I mean, come on.
No, you'll never replace it.
Nah.
We'll keep finding new things to investigate. Yeah. I understand that one of the things that a robot can do, or that is the instrumentation, is it stops the wobble when you're doing surgery. Yeah. So, and it's in real time, and you've got better visual optics than any of us have in our sort of high definition screens.
You know quite a bit about this.
Well, I spend more time than I really want to with research. I've actually been into.
But let me show you, because have a look at this.
So, tell me what you do.
This is the robot. Okay, let me just show you. This is just recently. Have a click here. So up there in the top left.
Yeah.
There's me on the right, and my fellow Elodie, a very attractive looking girl, from Belgium. She's there. And then you can see the robots in the background. We've just done the robot, we put it in, we blow the tummy up full of gas, some sort of gas. And it used to explode in the old days, actually, you won't believe this. And now
really?
the carbon dioxide.
Oh, that's cool.
Air seal.
Very, very comforting. Air seal.
Air seal.
Right.
And then if you look down the bottom, look, there's the poor bugger's head, the fellow who's been operated on. And then over here on the other side, that's the thing, that's the prostate. That's the prostate. Another thing on that.
No.
Stop.
When did you do that?
We keep them for posterity and tweet them
out. Because I think that's me. That's me.
The bloke.
Yeah, the good looking guy.
That's Elodie. Maybe.
No.
How far were you in last night, by the way?
No.
That's Elodie. She's my fellow. It's a female here.
The guy on the table is me.
What? The patient?
Yeah.
So, Penny, call a taxi for this guy. He's had one too many. I think time to go to the airport. Anyway, nice to meet you.
Very nice. Yeah. Thank you. So,
but seriously,
let me tell you about this reason why I'm on your phone and you're twittering me about all over the place. So, a lot of blokes get their annual checkup, and if you happen to have some other medication you need to go and have renewed every 6 months. It's not quite common to get a PSA. You know about PSA, a little bit. Yeah. So if you start monitoring it over time, you can get an idea of how it's changing over time. And I think probably it started about 49, and then probably 5 or 6 years during that process, my GP said, I don't like the levels of your PSA. They're not high, but they keep moving. And I think you should go and see a urologist. And I said, I know one at Peter Mac. Declan Murphy is his name, and apparently he's okay.
I didn't recognize you. I just usually bend over. Sorry.
We became very close in a very unusual kind of way. So Declan went through the actuarial charts of PSA for a man of my age at that time, and he said, we need to keep a watch on this, see what happens. Anyway, I kept monitoring it, and then a year or so ago, my GP said, Rob, you've got to go back and see Declan. I said, twice in a decade is too much for anyone. But anyway, I went back to see Declan. I said, look, my PSA is up. I think we need to do something about it. What should we do? And we agreed we should get an MRI, an imaging modality, which is very good at looking at the differences between different parts of tissue based upon the water content, basically. Anyway, we looked at the images together. The images showed that I had a shadow. Now, that brings me back, those of you who might have been at my conference talk. I got pretty familiar with looking at MRIs because we use them all the time in our MDMs. It's a really important part of the evaluation of patients, not only to work out where their cancer is, but to understand the mode of treatment that the surgeons and the radiation oncologists and the med-oncs will ultimately do. So we looked at this together. I saw a shadow and I thought, oh, this doesn't look great. Anyway, Declan, pretty cheery, said, no problem, let's just check it out. I'll take a biopsy if you like. So I had a biopsy taken, and indeed it came back positive for cancer. Not a big deal. Stage 2, Gleason stage 4, called level 7. And anyway, we decided an option of either getting it taken out or having radiotherapy. A very complicated decision depending on what age you are. So anyway, during the biopsy, I had the experience of hanging out with my colleagues once again. It was Bernard Riddell, he's the head of anesthetics here. He looked after me as I went under, and Declan got to know my nether regions to take a biopsy. And then, as we decided we needed to get surgery, Declan said, where do you want it? Want it done? I said, I want it done here. He said, really? Because a lot of people, when they get amongst their colleagues, they're very uncomfortable about having their medical issues dealt with by their colleagues. I'm completely the opposite. I want the best people to look after me. And I felt that Declan was the best, and I wanted him to do my surgery. And this fellow here, the robot that we have here at Peter Mac, is one of the newest, and it's really cool. And I thought, if I'm going to get it done, I'm going to get the best person to do it. There's a little observation I make about being a cancer researcher. I'm a lab-based person, but I have the privilege of spending a lot of time with clinicians. And the question I always think is the most pertinent is, if I have a friend who needs some treatment, I'll say to that medical oncologist or surgeon, what do you think you'd have done if it was you? And the answer they give you is pretty good information about who you should go and see. And that's what I've done for a number of my friends and family over the years. I said, go and see Declan. That's true. You know,
you keep sending them, but so far so good. But let's toast your good health.
Thank you.
And
so here I am now, and everything's gone.
So it's very interesting, isn't it? Because we, as clinicians working in the cancer center, we get the privilege of looking after patients, but a lot of the time it's colleagues or friends of colleagues, or somebody working in the building, someone working in the coffee shop. So one's been diagnosed with breast cancer, and then when you get to the point of, we've done a biopsy and there's a little bit of cancer, and Rob has health insurance like a lot of people have these days, and we're always happy to take staff to wherever they feel comfortable. If they want to be taken out to Epworth or whatever. And half the time I find colleagues and staff will say, yeah, I prefer to be done out of Epworth, and I keep work at work. But he thought about it, and he had a totally different attitude. It was very interesting. And I think the word you used was, you said, this feels like my family to me. I've been cycling into this hospital or our previous hospital for all these years now, and I feel safe and happy in here. And
you do have to feel safe.
Yeah,
that's true. The photograph that was taken by a colleague, Jonathan Hiller. Jonathan Hiller and I do anesthesia research together, we publish together, and Jonathan rang me up before my surgery. He said, it's Jonathan here. So, oh, hi there, I'm thinking about, ask me about some research. He said, oh, I'm wondering if you'd mind if I do your anesthesia. And I said, mind, I'd be delighted. So instead of trying to hide the fact that I have prostate cancer, I don't anymore, hopefully, I think you need to embrace it and learn from it. So what it does is, as a patient, you see the journey that the person will go through, from the anxiety, the concerns of family, and obviously your own secret concerns. And you see the way you're looked after by a specialist cancer centre. It's actually really quite gratifying. And as I said, you feel safe. And that's what I did. I felt safe.
It's a kind of a translational thing. It took your relationship with your clinicians to a different level. But
sure did. Yeah. We very, very intimate.
But Bob in his talk, he outlined how his journey as a cancer scientist took, really, I think you've talked about it before, a dramatic turn with your interaction with the colorectal MDM meeting. So I think we talk about this experience a lot in this cancer center as a way in which the rest of us in different tumor streams can try and do better to do this translational research thing. And one of the barriers, there are lots of barriers actually that we face, is sometimes young clinicians trying to get into surgical training or radiation training or medical training either don't have the time or the patience or the interest to devote time to lab research. Can I ask you for what you would say, tips for what you would say to young clinicians and trying to understand the value of it? I think when you're through the fire and Sandy Herriot and co will look back and mentors people to get through, but sometimes we find it difficult to motivate people to take that interest.
Well, I think sort of for this institution, this sort of campus, or before we moved, Bob Thomas was head of surgery at the time. I think he started that journey. He had a small number of trainees that went through and did their PhDs, and they've gone on to be fabulous clinicians, but they're different in that they're a bit more attentive to problem solving. They're a little bit more attentive to the unusual cases, the things that don't fit the normal journey that most patients travel. So they're better clinicians. And I think the program that we've been trying to build up in the GI area is that it's focused on training clinicians, particularly surgeons, as it turns out, but everyone's welcome in this place who has a clinical training to do a PhD. What they do is they change the way they think. It's a big challenge moving from the day-to-day experiences of running clinical practice to going into the laboratory. It's much more frustrating. There's many things that don't work, and it requires a different sort of horizon. It takes longer to get an experiment done than it does to do a surgical procedure. And you see all of them struggle. The first year, it's always a drama. If something hasn't happened fast enough, they get despondent, and you just nurse them through that first year, and then they get it, and they just take off. And we've had the joy of seeing them produce fabulous research. I would say between the people who are trained in Wayne's lab and my lab, we've won just about every surgery prize in the country because they do great research. They're really attentive to the opportunities that the research gives them to be better clinicians. And in the end, everyone's a winner because they're better clinicians and they want to help us to do research. So I don't have any problem getting to work with patient material because I decide upon what the experiments are that we need to investigate with my clinical colleagues. There's a classic problem with research in cancer space. Many researchers fall into a trap where they treat the medical oncologist or particularly a surgeon as an ATM machine. I'll just put in my card, give me some tumour, and I'll not talk to you again. That's actually a really disappointing approach that also doesn't achieve what we can achieve here. And the answer then is, I don't go there with my credit card, I go there with an idea and a willingness to collaborate, and then we form the questions together that are relevant to what happens in the patient. And that's transforming. You can do cool experiments still, but they're actually relevant to the patient journey rather than something that you can do gymnastically with the genetics of a mouse. I've done lots of mouse gymnastics. What I mean by that is I've knocked out lots of genes, made transgenics, bred them together, and got nice papers. But that doesn't light my fire anymore. It used to, but it doesn't anymore. So I want to do stuff that you and Sandy and Craig, they say, this is a problem, can you help? And as you can see from some of the research we're doing, it's focused on the questions which are relevant to the clinical journey of our patients.
I think you've got the whole attention of the bar. They're not even watching the replays. We might open the floor to them in a second, but before we do, just to be critical for a minute, it's quite a big operation actually, this pelvic cancer surgery business. And you go home the next day having keyhole surgery. I remember saying to you, take 4 weeks off when you talked to Maria. But how come I came into the colorectal MDM 10 days later and here you were in the front row? 10 days later.
can't keep away from it. It wasn't quite 10 days. I must have felt. It's Declan gave me advice about how long I should take off, and it was 5 weeks. I was really, really keen to be back in the lab at 4. I did come in a couple of times, and we had lab meetings. I wasn't allowed on my bike until 6 weeks, but I couldn't read the calendar quite right, and and I got back to karate. So I'm really delighted that it's on this way. It doesn't always go this way, but it goes this way more often than not now. So pretty scary to be diagnosed with cancer, but if you've got good people looking after you, there's a pretty good opportunity to come out the other side. So that's that. That's what it's like in the bar. So do you have any questions?
Yeah,
Those of you
the barman is over there. Martin. Yeah.
What's your beer doing?
This is like 0.4%, this thing.
Yeah, it's terrible.
Everything, and I'm doing a prostatectomy this afternoon downstairs. And you know, the anti-tremor thing, you're right, it's great.
But a bit serious here. I think we've got about 10 or 12 minutes before we have to close the bar. So there's plenty of room to interact with the panelists, I would say, bar panelists. Any questions from the room?
I turned 61 on last Friday, and I had my surgery in the beginning of April. So I was 60. Yeah, right.
Yeah, look, it's on a really serious note. The work that Rob has led on this insufflation stuff is amazing, to be honest with you. When we learn how to do laparoscopy, as all surgeons do, we learn all sorts of principles, but it's all focused on just getting into the abdomen safely, blowing it up, giving you a good vision, how to dissect tissues. We have never been taught anything about the physiological effect of the pneumoperitoneum, other than stuff like there are particular instances you can get at a gas embolism or a few dramatic things that are ultra rare, but not about the risk we pose to, I think, the cancer patient in particular by this environment, especially probably things like peritoneal cancer. So the answer to your question is yes, we have actually. AirSeal is this very nice system that came along about 5 or 6 years ago that means a recurring problem we have is leakage of gas, or when the assistant is sucking, you know, the pneumoperitoneum drops and then we lose our view a little bit, or things bleed a little more because the gas pressure drops. And AirSeal has this magic system that they've never explained to us because we're surgeons, we're not really necessarily, Rob, not capable of understanding.
Something like that.
Keeps the pneumoperitoneum. And I remember doing a live surgery demonstration in London about 5 or 6 years ago when AirSeal was coming out. And we only have 5 or 6 ports in the belly, and the belly is full up like this. And if you pull out a port, you know, you have this, the gas comes out and the tummy goes down. So the rep from the AirSeal company was in the operating theater and said, pull out 5 of the 6 ports. So we went, and the abdomen just stayed up. But there must have been enormous churning of gas in the abdomen. It was a dramatic display. And we, based on what Rob's team have shown, have stopped using AirSeal actually for this indication. I think it's probably okay for transanal stuff and certain other things where you need it. But I think when this word gets properly out in the surgical oncology community in particular, and there'll be a lot of questions about AirSeal.
So there's a concept in translation, research translation. We talk about the 2 valleys of death. The first valley of death is when a researcher does something, you know, that suggests it should be a practice change, and there'll be a small number of practitioners, clinicians, for instance, who will adopt that research and say, I'm going to use that evidence to change practice. The second valley of death is to actually get widespread adoption of that change. So if you have thought leaders and the key opinion leaders doing a new practice, it will encourage some people to change, but not everyone. And some people will never change. So the question always comes down to what is it that we can do as researchers to engage with our clinical colleagues to persuade them that the evidence is strong enough. And of course, you need multiple levels of evidence. It's cool to do stuff in mice because we can do some pretty amazing molecular biology. But as you heard, doing some work in the pigs is important because it's a large mammal, a lot more like the size of a human being. And then ultimately, we need clinical evidence, what happens in patients. So you put all the evidence package together and you give it at surgery conferences like I do, And it's up to the surgeons to change their view. But it's also up to the public to change their view, because they read the literature and everyone's on the web and they're looking around at what things happen during all sorts of medical interventions. And if you go to reputable places, all this work is published in top flight surgery journals, all peer reviewed. You make up your mind. Do you want to have a surgeon who is ignoring the possibility of doing unnecessary damage, or wants to go on to the right? So when I showed Declan the data, he said, wow, okay, I'll use the other device. And the important point was that is a kind of translation. I've encouraged the practice change, but I was actually prepared to put myself not blind, but I proved that I believed in it because I actually engaged in it. So that's reasonably good encouragement, isn't it? But I didn't tell you to do it on someone else. I said do it on me.
It's a problem with you gave a great example there of how you bring in change. But if there are people in the audience who are, medical oncologists or work in other fields where we rely very heavily on high quality research to affect practice change, surgery is a whole different basket case, isn't it? So the way a device like this gets introduced is the reps turn up and sort of knock on the door, get into operating theaters around the world. Same for every type of new surgical kit. And get the KOL surgeon to have a crack at it and see how they like it, and here's a basic paper, and that's it. The sort of regulatory environment for introducing surgical devices it's impossible to get over. And whereas when you bring in a new drug, the sort of hoops you have to get through quite properly to get a phase 3 trial registered and then registered in your country, et cetera, it's a totally different ballgame. Will we ever get over that?
Well, we're doing what's called a randomized clinical trial in this space, and others have done it too. In surgery, there was a very big surgery trial reported at ASCO, the American Society of Clinical Oncology, in June, which talked about some surgery research. They're being done, but we're probably not doing them as much as we need to. But the technology we need to get into practice to start using it, and then we need to set up experiments to work out whether it's doing any benefit or harm. There's certainly no question it's not doing any harm, but could we do better?
There's another question in the back there.
Yeah, I was wondering if there's any reluctance amongst clinicians to work on their friends and colleagues in case there was a good outcome. And another quick question, can we have full disclosure on exactly how long you're occupied?
You want to hear it first.
Full disclosure. My wife said, "What are you doing?" I said, "I'm just going to have a practice to see what it's like." I've got quite a few bikes, and I picked a bicycle with a very comfy seat at 5 weeks, and I felt fine. I really did feel fine, but you're a little bit uncomfortable down there for a while, and you do get a fair amount of feedback if you're doing something that's probably a little bit too early.
And just to explain, because the saddle bit, the bit that you sit on the saddle is exactly where we join things together when we take out the prostate and join the bladder. Actually, the sphincter, a very delicate place, so we wanted to deal with every time. And the first question is very important, but the way I'll answer that is to say, that this is what I say to all of our trainees, that to operate on a patient or to prescribe a drug for a patient or to be allowed to examine a patient is an enormous privilege. And I think, people get, that goes into the rear view mirror as trainees grow up. But it was hammered home to me by one of my big surgical mentors when I grew up in the west of Ireland, about what a privilege it is that another human being is allowing you to examine them or write a prescription or make a recommendation or do surgery. So I think that's a first important thing to remember, is it's an enormous privilege, and we never get away from that, or we certainly try in our team here to reinforce that respect. But second, yes, you're right. Operating on colleagues and friends brings a little extra burden, and I suppose you have to be confident that you're within your realm of expertise to do a good job here. And most of us nowadays tend to be extremely specialized in one area or another. And for me, that's prostate cancer. That's all I do is work in prostate cancer. And so I've taken my father-in-law's prostate out as well. That was fun. About 10 years ago. And again, it was a similar story. Comes up and says, "Oh, my PSA is up a bit." And somebody else did the biopsy for him. But, I said, "Oh, I think I should take the prostate out." And I did. And so I haven't seen him, but I haven't seen him. The mother-in-law still comes around.
I think just as well, there's another question here.
with your experiment with the mice, when you had the cold CO2 and the warm CO2, you had, with the warmer CO2, you got less cancer cell development, as I understood you to say.
Or less cancer cell attachment, and then subsequent tumor development. Yes, that's right.
Do you have a sort of understanding of the mechanism what causes that?
I think we have some understanding of it. Very simply, the surface upon which those mesothelial cells sit, that single layer, that surface becomes exposed because the mesothelial cells scrunch up and then they delaminate and they expose that surface. That basement membrane is rich in growth factors and it's a beautiful environment for tumor cells to attach to. If they then attach and allowed to grow, they will form a tumor in that spot. We're very clear about that. Some of the things I couldn't go into detail about, but when we started doing the mouse experiments, the very early ones, we found that we were getting runs of tumor development along particular lines. Then we worked out what we'd do was creating a gas stream across the peritoneum. You could almost direct where the tumor cells would embed and grow. But we didn't generate cancer by the technique. What's important is we introduced cancer cells into the peritoneum to ask what they did under those conditions. It's a very important point that we now understand that in possibly a quarter of patients that have advanced abdominal cancer, that they may have cells in the abdomen floating around. They're not doing anything because they've got nowhere to home and grow. However, it's my view that you don't want to create a place that they're happy to attach and grow to. So I'm just thinking about this as being better to be safe than sure. Better to be sure to be sure. Is that right? To be sure.
May I quickly follow up on one of the questions that you raised between radiotherapy and surgery? And that's a decision that many patients have to make at some point, which I think is a very difficult decision also. So from a patient perspective, what determines that decision for you? But also the evidence from Europe is that we've seen a huge increase in the number of prostatectomies at the cost of radiotherapy,
Yeah.
which is always supported by evidence. So from a clinical perspective, how would you deal with that and inform a patient about making the right choice?
Maybe I'll start. I did speak at length with my radiation oncologist. I spoke to radiologists who've been looking in the space as well. For me, it's a little bit about my age. I looked at the data. I also felt that perhaps if the radiotherapy, which works remarkably well, if it didn't work, then I'd be back to see a surgeon anyway. And I was concerned that looking at some evidence that Declan showed me as well, that if you go back after radiotherapy, it's a little bit more difficult, but you may never need surgery. That's the risk. So at 60, the way I read the data is that I want to be around for quite a while. I know my daughter's in the audience somewhere, I think. I think she wants me to be around for a while. So the idea is that you project where you are. I don't know I would have made the same decision at 75. I may have done it differently. So it's about your age, your risk factors, the amount of activity you want to maintain. So I just wanted to say one thing before you'll get me to answer this. I need to make a public apology to Declan, because what I did when he agreed to do my surgery, I said to him, "Don't you bugger it up." And I did that out of humour and also a little bit out of fear. I must say, I can't pretend I wasn't worried. And I didn't mean to put pressure on you like that. That wasn't my intention. It was really a backhanded way of saying, I do trust you, but I do know where you live, kind of thing.
I'll make a comment on that question because prostate cancer is a really classic situation like that, Martin, because we have really, well, 3 very good options for very many men with early prostate cancer. Number one, we can do nothing, which we're very keen on, actually. We've published data on almost 1,000 men we just keep an eye on. So active surveillance is a well-recognized strategy we're very keen on. And then you have surgery and radiation for those men who have a decent cancer and very good life expectancy who want to have that managed proactively. And so, what we do routinely is try and get everybody to see a radiation oncologist. And most of our patients who come and see us here actually or in our rooms are second opinions. They've been diagnosed elsewhere and come in for a second surgical opinion, but we re-emphasize, and I went out of my way to arrange that Rob would see one. He was geared towards surgery initially, but I said, you should see someone. So we got him to see one of our radiation oncologists. But that sort of equipoise does get lost, and I just think it's just essential to make sure patients are well informed about whatever decision they make. And I think the best way to do that is through a multidisciplinary team meeting, plus see those members of that team as required.
Great, thank you so much. And with that great answer, I think it's time to close the bar. Unfortunately, it's 2 a.m. It's kind of a
2 a.m.
closure. 2
2
a.m. for me. And, just kidding. And with that, I'd like to thank you both for a very entertaining conversation, a very informative conversation. On behalf of the FECCC.
Oh, thank you, Mark. Thank you. Thank you.